There are differences between the three drugs that are currently out there. Dabigatran was the first agent licensed. It's a direct thrombin inhibitor. It's taken twice a day, and it has two doses. At the higher dose, it shows a reduction in stroke compared to warfarin. Both rivaroxaban, which is also licensed in the UK, and apixaban, which currently isn't licensed, are what's called factor 10A inhibitors. Rivaroxaban is a once-a-day preparation and didn't show superiority to warfarin in terms of stroke prevention. Apixaban did. Again, apixaban is a twice-a-day dose and does show reduction in stroke. All three agents, however, encouragingly show a reduction in the most significant side effect, which is intracranial hemorrhage.
The major benefits of these new anticoagulants is that they do not require regular blood tests, and so that obviates the need for INR testing, which is a nuisance for a lot of patients. And the ease of administration means that, in general, provided the patients are compliant, that there will be a smoother anticoagulant profile. The side effects are rare in these drugs, with the exception that with dabigatran there does seem to be a problem with indigestion and GI bleeding in some patients. The indigestion situation can be reduced by taking the drug with food and does seem to settle down with time. But again, we have to wait until we see how it behaves in real life.
It's important that we do try to address the risk of bleeding, simply because when a patient does bleed on any anticoagulant, the therapy needs to be stopped, and when you're stopping therapy, you're putting the patient at risk of a thrombotic event. So in terms of how we can manage the risk, for AF it's quite simple. There's the Has Bled score, which takes you through the risk factors for a patient who for bleeding. When the patient has 3 or more points, they're high risk. And there are a number of modifiable risk factors, such as hypertension. Uncontrolled hypertension will increase the risk of a bleed. So we need to look at, is the patient on the right medication? Is it appropriately controlled? And then other drugs, is a patient on drugs such as NSAIDs or corticosteroids or SSRIs? All these will increase the risk of a bleed, and can we change their therapy to minimise that risk, so we can be proactive in managing it. Also, we can ask the patient to take the drugs with food, and we can also consider PPIs, proton pump inhibitors, for gastroprotection.
When we look at these new medications, they're clearly more expensive. NICE has told us that they're cost effective, but the question is, are they affordable? They are affordable if we look at trying to reduce the cost of atrial fibrillation in the system. And I would suggest that we use this opportunity of the attention being on atrial fibrillation and stroke reduction to look at the whole AF pathway and try and improve the management of AF, not only for the symptoms endured by the patient, but also for the cost endured by the system.